Good morning. I would like to welcome everyone to Aspire Talk today on the topic of PGT-A or no PGT-A in ART. I am Dr. Somjet Manipan Virat from Thailand. I am a reproductive endocrinologist in Bangkok, Thailand, and I will host the talk today. And I would like to introduce Professor Catherine Rakowski to the talk today. She is Professor Emerita of Obstetrics and Gynecology at Harvard Medical School and was Director of the IVF Laboratory at Brigham and Women's Hospital for over 20 years. She currently is a university consultant in the Department of Obstetrics, Gynecology and Reproductive Medicine at the Foch Hospital in the suburb of Paris, France. She received her Bachelor of Arts in Zoology at the University of Oxford, and her PhD was in reproductive physiology from the University of Cambridge, and she undertook her postdoc fellowship at Harvard Medical School. Professor Rakowski was a past president of ASRM, and she also was a past associate editor of Human Reproduction and currently is associate editors and member of editorial board of many high index journals in reproductive medicines. Her research interests include investigating maternal and environmental factors affecting oocyte quality, studying the molecular and cellular mechanisms underlying oocyte maturations, and expanding methodologies for assessing human embryo development competency. She has authored more than 190 peer-reviewed papers and has published many book chapters, books, and she has mentors numerous clinical trainees and embryologists in reproductive medicine.
Well, thank you so much for a very kind introduction. My pleasure to be here.
Nice to meet you online. So today, I think we had quite a few issues that we can discuss, and then we can talk based on your expert, okay? Because nowadays, PGT-A has been introduced into our practice and become common in many practice. Before we're gonna get started, I would like to ask you on how common is the utilization of PGT-A in the United States?
So this is actually a tricky question to answer because we don't have the data. However, if we look at the Society of Assisted Reproductive Technology report for 2021, which is the most recent report, we find that utilization of PGT for all the different indications, the 4 indications, is around 50% overall for all ages. And then if we look by patient age, we find slight differences. For under 35-year-olds, the utilization is 50%, again, for all PGT. 35 to 37-year-olds, it's 58%. For 38 to 40-year-olds, it's 56%. 41 to 42-year-olds, 48%, and over 42-year-olds, 32%. So if we assume that utilization of PGT-A for aneuploidy is probably about 80% of the overall usage, then I think we can conclude that use of PGT-A in the United States is of the order around 40% across all ages.
All right. Do you have any difference between private and academic setting? Is there any difference in terms of the usage?
That's a very interesting question. So there are actually, so between private and academic settings, I, to my knowledge, would say there's probably no difference. I think it's more to do with costs, and I know that we're probably later on going to discuss the cost of PGT-A and how that might inform usage.
All right. Thank you very much. And as almost half of the cases are now incorporating PGT-A, so do you think in the future, should PGT-A be offered to everyone who comes for fertility treatment?
So I think in order to answer that question, we have to think about what the main underlying reason for PGT-A is. And that, of course, relates to maternal age. And if we look at the incidence of aneuploidy by maternal age, we find that it really, really substantially increases over the age of around 37. So, for example, Jason Franasiak's study with a very large number of embryos when he was working with Richard Scott showed clearly that there is this dramatic uptick. So, in women that are 30 to 34 years old, it's the aneuploidy rate is around 30%. In 37-year-olds, it's around 45%. And then we see this dramatic increase. 38-year-olds, it's 50%, 40-year-olds, 60%. And in women that are over 40, it can go as high as 75 to 80%. So then clearly, in women that are less than 38 years old, the aneuploidy risk is less than 50%. And several studies have shown that there is some selection against blastulation if the embryo is aneuploid. So we have to also consider that. Therefore, logically, when one, I think, is considering maternal age, when weighing the value of PGT-A against this risk, I would answer no to your question, that
Mhm.
PGT-A should not be offered to anyone coming into the clinic for infertility treatment.
All right. So at the moment, PGT-A may not be suitable for everyone. It could be more of the benefit for those who are older than 37 or 38 years old. Am I right?
Correct. Yes, based on what I've just said, obviously maternal age is, a strong indication for
Yeah.
PGT-A.
Oh.
However, what might be the cutoff
Mhm.
age above which it is reasonable to use it? And that's really, I think, the critical question. And there have been many, many studies that have looked at this. So let's look at the evidence very briefly. So early studies investigating outcomes following transfer of a single embryo that was deemed euploid showed higher live birth rates and lower miscarriage rates. These early studies didn't necessarily take into consideration maternal age. However, the largest randomized controlled trial that was performed by Monet et al., published in 2017, this is the SMART trial, actually showed that maternal age did seem to have some relevance, and that patients that were between 38 and 40-year-olds apparently had an improved live birth rate as compared with those that were younger. However, there was a big caveat in that statement that they used the denominator per transferred embryo and not intention to treat. And so if the data then is recalculated by intention to treat, we see a very different story. We actually see that PGT-A was not helpful for any patient, regardless of patient age. Having said that, there are other studies that have shown that clearly age does come into play and is important. And generally speaking, the thought is that patients that are 38 or over are going to benefit most from application of PGT-A. However, there are other studies that have actually looked at this in more detail and have actually shown that women that are less than 38, actually PGT-A is harmful.
Oh, that's great.
This is a study, particularly that was published, I believe it was in 2019 from the Boston IVF group, that showed that cumulative live birth rates were actually lower in patients that used PGT-A if they were under 38 years old. And this presumably is because of deselection of embryos along the way for, all the different reasons that we know in terms of not having embryos that are suitable to transfer because to biopsy because of morphological indications, etc. So then we have maternal age as one key factor that should be considered, which is an indication. Also, in younger women who have failed previous cycles, it perhaps may be advantageous for them to have PGT-A. Very critically, patient counseling is of paramount importance in discussing with patients whether utilization of PGT-A actually is going to be of benefit to them. So in addition to maternal age indication, then we have to think about perhaps 2 or 3 other indications, potential indications.
Yep.
One of them is recurrent pregnancy loss.
Mm-hmm.
And if one looks at the literature, one finds that the data is, as is so often the case, unfortunately, in our field, somewhat conflicting. But nevertheless, I would say overall and on balance, even though the quality of the evidence is low or very low, it does seem that PGT-A is beneficial for patients who've had 2 or more recurrent pregnancy losses. So that would be a second indication. And then the third indication that one might consider is repeated implantation failure. Again, looking at the evidence and considering the balance of the quality of the evidence and the studies that were involved, it seems unlike with recurrent pregnancy loss, with repeat implantation failure, there does not seem to be any benefit. So I think that probably is not suitable to be considered as an indication. And then what about young PCOS patients? We all know that the quality of eggs in PCOS patients tends to be lower than in a non-PCOS population. And there are a couple of studies that have shown aneuploidy rates are higher. So it might then be reasonable to consider using PCOS as a criteria for PGT-A, again, depending upon the patient profile, her preferences, and all the rest of it. So returning then to your original question, what are the main indications for PGT-A? Maternal age clearly is one. Women who are 38 years of age or older, they're going to benefit more. And in fact, there is data now that shows applying PGT-A overall in general to patients that are under 38 actually is going to introduce harm. Their cumulative live birth rates are going to be lower in general. Patients with unexplained recurrent pregnancy loss, that is at least 2 or more losses, may benefit from PGT-A. And then perhaps selected PCOS patients, particularly those, and most PCOS patients are like this, that have a large high yield of oocytes, may actually benefit. But the concluding point that I really want to make is that appropriate use of PGT-A lies in appropriate counseling and careful application in selected patient populations. This really has to be applied in a personalized approach with a lot of discussion between the patients and the physicians, with hopefully informed physicians that can actually provide the evidence to the patients when they're considering whether or not to use it.
Thank you so much. So from what you had told us, it seems that PGT-A may benefit some people, not everyone. And it is very important that we have to have a detailed counseling and discussion with the patients for proper, correct understanding and to have a correct expectation from the PGT-A. Because some may look at the PGT-A as a risk-free, just like to make sure no miscarriages, 100% pregnancy. That is something that has been put in some patients' mind, in which it is not true scientifically. That we have to be clear before introducing patients. And let me go back to your message that you have mentioned that the study has shown that for women who are younger than 38 years old, who perform PGT-A, besides not improving the cumulative pregnancy rate, but it even make it worse to lower the cumulative pregnancy rate. Would that be related to the fact that you mentioned that that publication was from 2017? By that time, we did not make use much of the mosaic embryo. Would that be the reason why PGT-A may deselected the mosaic embryo, but with the more informations and more utilization of mosaic embryo nowadays, would that change the outcome on that publication?
I mean, that's a very interesting question and one that I can't clearly answer, but I think yes, perhaps now with high utilization of mosaic embryos, that could perhaps improve the live birth rate of the women that are under 38. However, I think one also has to consider what we're actually doing when we actually perform the pre-implantation genetic test for aneuploidy. Obviously, we can only biopsy embryos that are morphologically suitable quality, number one. Number two, there's obviously going to be further attrition because not all embryos will provide an informative result. And number three, of those that are called euploid, Not all of them, unfortunately, may have survived the vitrification, freeze and thaw process, warming and freezing and warming process, and so therefore may not be suitable for transfer. So I think one has to be very careful when actually perhaps saying that mosaicism, higher utilization of mosaic embryos might actually improve the live birth rates overall. I do think that it depends so much on the platform that is being used, and how the mosaicism threshold is set by the testing company. There's a great deal of confusion in this field about this. And I think the onus is on the clinics to really understand if the testing company has done the appropriate validation work to prove that the test that they're offering actually has efficacy or not. And unfortunately, and I'm embarrassed to say, but I think we would all probably agree that we've moved technologies into the field prematurely, and that not always has the appropriate work been done before we've actually started to use the technology on patients.
I love that. I think it's very true. In our field, it seems that sometimes once technology gets in, we adopt that into practice before, well-studied research has been implemented. That is something that we have to be very cautious. And well, let me ask you about the PGT-A. If we consider the cost effectiveness, do you think that by incorporating PGT-A into fertility treatment, will that reduce the cost per live birth?
So this is another very tricky question to answer. We don't yet have the data for me to be able to answer definitively yes or no to this question. But I think it's worth just thinking about the different variables that come into play when considering the overall cost of the technology. So we've obviously got the embryology time to perform the biopsy, if trophectoderm biopsy is used, and I think we'll be talking a little bit about non-invasive PGT-A shortly. The test itself is costly. It varies hugely in the United States. It can vary from a cost per embryo of around $150 to $200 per embryo to what's called batch costing, which can go to around $2,000, $2,500 for up to 8 embryos that are biopsied, and then the cost then gets charged on an embryo basis after that. So there's the cost of the test itself, but these costs I think must be balanced against the lower cost of fewer embryos needing to achieve a live birth, so fewer transfers need to be performed. The increased incentive to perform single embryo transfer. So there'll be fewer multiple births arising from PGT-A, and that is very clear. There's also the reduced risk of aneuploid miscarriages, which are going to be costly to manage, potentially. Risk of a person with the abnormal number of chromosomes being born, such as Down syndrome, for example, where there might be an increased lifetime cost to take care of the individual. So there are all these different aspects of the costs on the pro and the con side. And in addition to that, I think not necessarily a financial cost, but the emotional stress to the patients for undergoing more transfers if PGT-A is not performed, and in the woman, if a woman perhaps is, for example, 40 years old. So overall, I think it is actually unlikely that adding PGT-A to a cycle will reduce the cost per live birth, except perhaps in women of advanced maternal age. However, a cost analysis really needs to be performed by a skilled health economist to really be able to evaluate this question with real numbers and really help inform our field.
Yeah, that is very helpful. I think we may need more data on this before we can say if it is going to reduce the cost per live birth. And also, I would say that the cost may differ from one country to the others, from one setting, from private versus academic.
Absolutely.
There are differences that we have to take into considerations, not to just read the articles, but probably we may have to come up and calculate on our own based on our circumstances to get to the answer for yourself.
Absolutely.
Yeah. Before we're gonna end this sessions, I would like to move a bit to the future. Now, many people have been talking about non-invasive PGT-A. My question is, are we close to adopt that into the clinical practice soon?
Difficult and interesting question. I think the short answer is no. And I'll try to elaborate on that. So first of all, what might be the advantages of non-invasive PGT-A? Trophectoderm biopsy is invasive. Although safety studies have shown that it probably is safe, there does not seem to be any really concerning outcomes yet, but a lot of work still needs to be done in that regard. But there are also inherent limitations to trophectoderm biopsy vis-a-vis the mosaicism aspect, for example. So with non-invasive PGT-A, obviously we're characterizing the DNA that is released from the embryo into its environment. And by this, I'm talking about the spent culture media. But when we think about whether a test actually is ready for clinical use, we've got to think about the accuracy of the test. We've got to think about the clinical validation of the test in non-selection studies, and then ideally also have performed randomized controlled trials. So although promising results have been obtained with studies using non-invasive PGT-A, there are really hurdles, I think, that need to be overcome in order for it to become used routinely in clinical practice. The problems arise due to DNA amplification failure, contamination, particularly from maternal DNA arising from the DNA in cumulus cells, if they haven't been sufficiently removed from the oocyte, and then prior to ICSI. And then, of course, inaccuracies. We have to think about the performance characteristics of the test. So of this three-phase approach that I've just enumerated, they're really only, the studies to date have really primarily focused only on test accuracy, with very few studies on predictive clinical value and no RCTs. So to answer your question, whether we're close to actually utilizing non-invasive PGT-A, I would answer no, but interest in this technology continues. Ongoing research looks promising. Much more work needs to be done in order to be able to prove the precision and reliability of the test that's needed in order for it to be applied clinically.
Right. Thank you very much. So it is very informative and very interesting discussion and talk for today. To answer the questions whether PGT-A or PGT-A in ART, I would like to say PGT-A is recommended for some people, but not everyone. Mainly at those who are with advanced maternal age, who are over 38 years old. For those who had recurrent miscarriages for 2 times or more, it is still questionable for those who had repeated implantation failures. And it also could be considered in those who had young PCOS, who had many embryos, that are those who may benefit from the PGT-A. And now we still do not have the information to say PGT-A will reduce the cost per live birth, but it is something that we may have to look into it to see if it is or it is not. And in the future, we may have to move on more research in non-invasive PGT-A. But again, I would encourage data, better, well-organized, well-implemented studies before quickly adopting into clinical practice. Otherwise, we're going to go back in the same loop as PGT-A that we have now today. Thank you very much, Professor Rakowski. I would like to thank on behalf of ASPI Education Committee that you had provided us very insightful information. Thank you so much. And have a good day.
It's my great pleasure. Thank you so much for inviting me. Thank you.
Thank you.